okay? So we are here to talk about how to approach difficult topics and sensitive topics with our clients. And so I'm going to share the screen. And again, if you have any kind of questions, if you have any comments, please comment or turn your mic on and actually speak, because I'm all about the engagement of my participants. So this is how to broach sensitive and difficult topics with our clients. And again, it would have been Megan Concannon if we did not have technical issues. And myself, I'm Shari Wall. I am the head recreation therapist at Rockland Children's Psychiatric Center. And Megan is the senior recreation therapist at New York City Queens Children's Center. So today, we're going to talk a lot about different types of trauma. But the first thing I want to talk about is our learning outcomes. You're going to be able to identify at least one skill that's needed to present quote unquote tough topics in a safe and creative practice of recreation therapy. You'll be able to also learn at least 2 beneficial treatment modalities that you can use when discussing difficult and sensitive topics. You're going to be able to identify one benefit to learning how having these conversations about difficult and sensitive topics can really benefit and strengthen our therapeutic relationships, as well as promote collaboration and recovery within your patients. You're going to be able to identify at least one way to modify your modalities that can be applicable and relevant within your various populations. You're also going to be able to identify at least one method of how to communicate effectively and empathetically in all of your interactions. And I think that for me is the most important lesson of them all. And I hope that that's what you can grab from this. And finally, you're going to be able to identify one benefit to trauma-informed care when working with our clients in various settings. So I want to start with this graphic here. And it says, healing is cumulative. Every skill gained, every healthy boundary, every step forward, every day that we don't give up, every bit of self-confidence builds on each other. And I think that that's really super important to really recognize, because, you know, in day to day, as we are going through our processes, and I'm not just talking about our patients, I'm talking about as humans. Every day we're going through the day to day, but we're not recognizing how far we've come. And I know that that's the case for my patients. So I work in psych, and those of you who work in psych, I know that Lanny works in psych. I'd like to know if everybody in this group does work in psych, or if there are any other populations, because no matter what population you're working with, we're gonna be talking about how much we can move forward, right? And a lot of times we don't realize how far we've come until we look back. And we realize how cumulative that healing really has been. Okay, I've got a chat. So, okay, so Donna says she works in nursing and rehab, and that's really great. And I'm glad that you said that, Donna, because we're gonna talk a lot about how it's not just in psych that this kind of stuff happens, and these kinds of modalities are important to be utilized, okay? So I made sure to really identify specifically how we are going to be able to apply this to different populations. So I hope that you get a lot out of it. We've got 2 more chats, so let's see what we've got here. So I see nursing and rehab and a youth residential treatment facility for behavioral health. Wonderful. So we've got the spectrum here, and I think that's really great. And I'm glad to see that we have people from all different facets. So hopefully this will apply, and I think it will. So let's keep going. So what really are considered our difficult and sensitive topics? So we have abuse, with, you know, physical, emotional, sexual. But let's talk for a second about perception versus actual. So the words trauma and triggered, they get around a whole lot these days. I once had a kiddo tell me that doing yoga in the gym was triggering her. Okay, so what was triggering about it? But here's the thing. You saw my face that I just made, right? Here's the thing. If the client perceives the interaction as traumatic, do we have the right to tell them it's not? Because If you tell me that my whatever happened to me is traumatic and you tell me it's not, what's going to happen? Okay, so Kathy used to work in psych and now she's in a memory care unit. Great. And so Fatima is saying, no, we don't have the right. And I would agree. I don't think we have the right to be able to tell somebody that their trauma was not as important, even though maybe it wasn't actual, maybe it was perceived, right? Do we have the right to play trauma Olympics, meaning mine is more important than yours? Because everyone's perception is exactly that. It is perception. And it has real effects on our lives, our relationships, and our ability to engage in our daily interactions with others. And that for me is really important. And I noticed that when, I've worked in various populations. I've literally worked in every single population you can as a rec therapist. And I always seem to come back to psych. But no matter where it is, you'll find that you have people that are trying to one-up each other. And that's not really a healthy way of living, but it's human nature. So we'll talk more about that. So then we have illness, physical or mental. Let me ask you this. Do you think it's easier to talk about physical illnesses or mental illnesses? Because my other question is, would you be more uncomfortable talking to a client about their newly diagnosed diabetes or their newly diagnosed diagnosis of bipolar disorder? Because I've had it where I've been more uncomfortable talking to my patient in a skilled nursing facility about his diabetes than I did talking with my patients about their schizophrenia. Because the patient that was, diagnosed with the diabetes was absolutely not really engaging in his treatment and was very angry with us for trying to engage him in his treatment. So, food for thought. We as therapists, we have to figure a way to be able to discuss both illnesses with equal care and consideration. So, I want to talk a little bit more about others. So we have loss and we have grief. We have a comment too, great. So Donna says she thinks it's easier to talk about illnesses regarding less of a stigma attached to medical issues. And you bring up a really great point. So think about this. When I used to teach my understanding mental illness to my patients in my forensic psych unit, I used to talk about how, there's definitely a stigma when we talk about mental illness. But what about even in the physical diagnoses, right? If somebody has diagnosed with, let's say, breast cancer, but if they're diagnosed with lung cancer, well, did they smoke? They brought it on themselves, right? Think about type 2 diabetes. Which because they're obese. Here's the thing. Again, we're going into that idea of trauma Olympics, right? Who is to say that just because somebody is obese, do they bring on diabetes to themselves? Do they bring on any kind of physical illness, or is it genetic, right? We're not doctors. Certainly we can't make that determination, but we still need to recognize that every person who's going through something, they're going through something. And we as their therapists have to help to support them through that. Really great point, Donna, thank you. So let's talk about loss and grief. Do you think that it's just death? Because I don't, right? Could it be mourning the loss of autonomy? Think about, I'm going to put this here. Think about your clients in your skilled nursing facilities, right? Some of them have lost their independence, their ability to leave their homes, or even the ability to choose what they're going to have for dinner that night. And honestly, I talk about this a lot in my classes, and one of my students is here with us tonight. And I think that she'll definitely agree that I talk a lot about autonomy when it comes to especially our patients, okay? Here's the thing. We get to go home at the end of the night. We get to take off the badge, we get to take off the keys, and we get to go home. We get to choose if we're going to go into the bathroom. We're going to choose if we want to cook dinner or order out. Our patients in all of these different various populations, they don't get that choice. And so when they are newly admitted, right, it's a lot of trauma for them. And it's a lot of loss of that independence. okay? I once had a kiddo tell me that, you know, what was really upsetting to them most of all, it wasn't, you know, that they had to be in this facility. It was that they had to ask somebody to open the bathroom so they could go to the ladies' room. And I get that. And so talking about that loss is huge. What about a physical use of your body or your limbs? Right? I mentioned the other day that my uncle was diagnosed with ALS. And he's the reason why I became a recreation therapist. And this is specifically because I watched this man who was stuck in his bed for 2 years. And the only people who came to see him were his family and his recreation therapist. And for him, the joy that came on his face when either of those two types of people walked in the room, it was amazing to see. And this is how I became a recreation therapist. But think about this, right? What do we talk about, especially if we add it back with our, you know, physical illness? Let's say I have diabetes and I lose a limb because my diabetes was not controlled, right? And here I am grieving all of this all at once. Here you are as my therapist trying to talk to me about it. What about a loss of a relationship? I think we don't really give that enough, you know, power, because that in and of itself, it's a real and true emotion that many just push under the rug, right? It's life changing. And it doesn't have to be specifically a loss of a loved one, right? It doesn't always have to be that significant other. Kathy is saying, especially they're not going to come home from the hospital. So the patient was not there when the family dismantled their home. Oh my gosh, that's traumatic, Kathy, absolutely. So I'm so glad you brought that up. We're gonna keep talking about that. So keep giving me more, okay? But let's talk for a second about that loss of relationship. It doesn't have to be that significant other. It could be that, you know, you have a friendship that ends, a family member that you no longer talk to, that you might have been close to, and now for whatever reason, you don't have that anymore. We don't give that enough value in our lives to recognize that that's a true trauma, okay? And oftentimes we want to shy away from these discussions, but we don't want to trigger our clients, right? Oh, we got a comment. Let me make sure I put that in here before we go forward. Hold on. Sorry, guys. So, loss of a pet. Yes, Fiona, absolutely. Because I'll tell you, when I lost our cat, it was as if I had lost a sibling or a child. I was certainly really like, it was devastating to me. And that was 10 years ago, and I still miss her. So absolutely, those are our family too. Great point. So like I said, oftentimes we shy away from these discussions because we don't want to trigger our clients, as I put in quotes. But if we don't learn how to talk to them, we're going to keep perpetuating that idea that it's something that shouldn't be discussed or addressed. And so when I was originally recording this session, I made the point of saying, you know, back in the way back days, when somebody was diagnosed with an illness, it was whispered, she's got the cancer. She lost a baby, right? Why? Why is it whispered? Why isn't it something that we are not willing to talk about, right? 1 in 8 women will lose a child, right? Through miscarriage. You don't talk about that. It is something that is not discussed, right? When people have cancer, it's whispered until they're ready to talk about it. Why? That needs to change. And so also, I want to tell you guys, I added this slide in the last couple of days because I think it's really important to talk about what is going on in this world right now. It's the elephant in the room. It's grief over racial or social unrest. How do we talk to our patients about this? We would be remiss if we didn't talk about being culturally competent in the face of what is going on in the country and around the world right now, right? It's not an easy topic to discuss. And even though it's not, if we don't talk to our clients about that, if we pretend that they're not hurting now, we're actually going to do more harm than good. We're talking about people of color. We're talking about people who are LGBTQ, religious hate, global issues that are occurring as we present this right today, right? We have unrest going on in Israel and Gaza right now as we speak. And this is something that a lot of people are dealing with, right? There's a rise in white supremacy and Islamophobia and anti-Semitism around the globe, but especially in the United States. And we here in the US, if we don't talk about this, we're not going to move our society forward. So how do we do this? First thing we have to do, we have to talk about trauma-informed care. So what is it and how does it affect our practices? Oh, I've got a comment, sorry. Let me make sure I have that in there. Lanny's talking about bullying people on gender issues. Yes, this is stuff that we need to talk about, 100%. So trauma-informed care acknowledges the need to understand a patient's life experiences in order to deliver effective care. And it has the potential to improve patient engagement, treatment adherence, health outcomes, and provider and staff wellness. And I want to say that again, provider and staff wellness. It is not just about your patients. It is about your ability to deal with what is going on, right? You are affected by your patient's trauma. Whether you realize it or not, it affects your life. And we're going to talk about how. So trauma-informed care must, and notice that I underlined it and I bolded it. It must involve both the organizational and the clinical practices, okay? And it must recognize that complex impact that trauma has on both the patient and the provider, okay? If it does not, then it is not trauma-informed care. Because well-intentioned healthcare providers, they'll train their clinical staff, that's us, in trauma-specific approaches, but they don't implement the broad changes across their organizations that address trauma as a whole. And that's really, really important. So this comes from the SAMHSA website, and I put the link down there. And if you'd like, I can email you guys the PowerPoint once we're done with both sessions so that you can click on the links as well. So let's talk, we're gonna go so in depth with trauma-informed care. So hopefully if you've already had a little taste of it, we're gonna talk a lot more. And if you've never heard of it before, I hope that you're going to learn something today about it. So take a look here. So from an organizational perspective, trauma-informed care changes the culture to emphasize respecting and appropriately responding to the effects of trauma at all levels. It's not the intention to treat the individuals, rather, it is to provide support and related services in a way that's accessible and appropriate to those who have experienced trauma. And the risk for triggering or worsening trauma symptoms and re-traumatizing individuals increases when we are not using this approach. So I want to stop the share for a second because I want to ask you guys, how many of you in your practices already employ trauma-informed care? Is there anybody who already does? Okay, so hopefully, I thank you, Dan, for shaking your head no. So hopefully, those of you who work in these kinds of facilities, and I mean all facilities, will actually be able to start championing for this as you move forward now. So trauma-informed care follows 5 guiding principles. The first one, first and foremost, it is safety. We must ensure the physical and emotional safety. And this is by even just when you walk into the building, welcoming common areas and respecting that privacy, right? I'm not going to take a patient into the day room and ask them about their trauma history because it's not appropriate and it could lead to more harm than good. Choice. And again, Goes back to that autonomy over and over. And I think that, you know, I touch so much upon autonomy and choice because we know how important it is in our lives. Think about how many choices you make in a day, right? And think about if you had even half of the ability to make those choices, half it, quarter it, now you've got our patients. So we need to have clear and appropriate messages about their rights and their responsibilities, okay? And we're talking about patient responsibilities and staff responsibilities. The patient responsibilities is to actually engage in their treatment. The staff responsibility is to make sure that trauma-informed care is being followed. So then there's collaboration, making decisions with the individual and sharing power. And so I like to talk a lot about Austin's health protection, health promotion model. And for those of you who are out of school for years and years, I'm going to give you a little bit of a quick refresher. Austin says that there are 3 stages to health protection, health promotion. The first one is prescriptive, where it is me in the driver's seat as the rec therapist and my patient's all the way in the back, and he's saying, where are we going, Shari? And I'm like, okay, I'm going to take you there. We're going to start with this activity, and here's why, right? And once they get to the point where that intrinsic motivation kicks in and they're really engaged in their own treatment, we get to the second part, which is recreation, where we are now both. I got a passenger in my front seat here, right? It's me on the driver's seat, but I got my passenger who's the patient, and they're saying, okay, so if you make a left here, if you go that way, we're going to have a really great time, right? Awesome, let's do it, because now we're making mutual decisions about your treatment. When we get to that third section, ooh, that's the best part of all. I call it where the baby bird takes flight out of the nest, right? This is where your patient is in the driver's seat and you're in the back seat going, where are we going? Let's do it. Sounds like fun, right? So when we get to that point, when we're collaborating and we're in that second stage, right? This is where that individual, your patient, has the power to help themselves. That's where that trauma-informed care comes in, because they're feeling empowered to be able to collaborate with their treatment team for their treatment. They have to take a significant role. And we know this, I'm sure every one of you know this, that when your patients are engaged in their treatment, what's going to happen? They are going to improve a lot better. I see Lani shaking her head, yes, right? And it's true. We know that when they're motivated, they're wanting to participate. They're engaged. They're giving you songs. They're giving you movie ideas. They're saying, I think this would be a great thing. Can we do horticulture? Can we do blah, 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 whatever it is? And they're more willing to come to our programs, and they're more willing to be engaged in the treatment. And that right there is the best feeling ever. So, trustworthiness. We've got test clarity, consistency, and interpersonal boundaries. That is super important, right? They have to know that they can trust you. They have to know that we have a therapist-client relationship, right? We have to make sure that we're maintaining our respectful and professional boundaries. And I'm sure this is not brand new information for any of you guys, right? But this is a guiding principle of trauma-informed care. Because if we are not informed and engaged, they're not going to trust us. They're not going to want to be able to move forward. Finally, we've got empowerment. Again, they're in the driver's seat. I'm in the back seat just going, where are we going? Take me there, right? We are prioritizing empowerment and skill building. And basically that's what rec therapy is, right? We are giving them that atmosphere that allows them to feel validated and affirmed with each interaction, with anybody. And I'm talking from the executive director down to whoever you would consider at the bottom, because honestly, I don't consider anybody at the bottom. Let me tell you, who was it that was talking yesterday about how those support staff are your make or break, right? We absolutely need to make sure that we are engaging all of our coworkers, right? But empowerment, it is so, so important because literally that's what we're teaching them, that skill building. And if we can't get them to buy into their program, okay, so I can teach you everything, but unless you're ready to do it, I know how to do it. And that's great for me, but I'm not the one who needs the treatment, right? So that comes from the nrpa.org site. And again, I can send out the link so that you guys can click on it yourself. So how do we make sure that we're implementing this type of practice in our daily interactions with our clients? We have to acknowledge that even though you might not work with that specific population that traditionally does address trauma, right? Those of us in psych or drug and alcohol rehab, you are going to interact with people who've had experiences, and it will affect every moment of their lives, even if they don't realize it, right? And I'm talking from skilled nursing to community, right? We don't know what people have lived through. Every person in this quote unquote room has had some kind of traumatic experience that they perceived as trauma in their lives. And again, we're not going to play Trauma Olympics, and we're not going to say, well, that's not really trauma, because if it was what I perceived as traumatic, it is. And I have to learn how to deal with it. So we need to be versed in trauma, and more importantly, how it affects the development, the growth, and our interactions with others throughout the lifespan. So in the next couple of slides, we're really going to go in depth about trauma itself, okay? So we need to identify firstly the difference between stress and trauma, because there are three types of stress. Firstly, there's positive stress. And I'm talking about like, okay, I have a big exam coming up, or I have a presentation to make, right? Let me tell you, this is stressful, and it was motivating because I knew I had a deadline and I had to get it done. So developmentally, the appropriate the appropriate levels of stress can be growth producing, right? And it comes from here, it says here, children's goals, but really, this is for across the board. Think about the last time you had a deadline, or you had something that was stressful, but was something to work for, right? That kind of stress, it's normal. We learn how to adjust to it. And this is how our frustration tolerance and our anger management kind of begins even in the early lifespan. Then we have what's called tolerable stress, which refers to the responses that, yeah, okay, so it might affect the brain, but it's quick, right? It's something that, okay, it was stressful in the moment, but it didn't have long-lasting effects. But then we have toxic stress, and this is the bigger one of all. This is the strong, frequent, prolonged activation of our body stress management system. Stressful events that are chronic, they're uncontrollable, and they're experienced without the person. And again, it shouldn't say child specifically, but the person having access to support from caring individuals, right? This is where we are, okay? This is what trauma-informed care is all about. It's recognizing the effects of different types of stress and how toxic stress becomes trauma. So the physiology of stress, let's talk about that for a second. And I'm sure that you guys have covered this in anatomy and physiology, but I don't know about you guys, but my anatomy class was 13 years ago. So I like to keep myself kind of, up to date on the different things. And I'm sure that you remember, but our bodies have the response to perceived threats, which is the fight or flight response, right? In response to stress, that chain reaction results in the production of cortisol, which is quote unquote the stress hormone, and it triggers a change in our entire nervous system. And what I like to talk to my patients or my students about is, if you've ever been on a roller coaster, what happens when you go up on that first drop? What happens to your body? Anybody? Maybe you're gripping the the thing in front of you, right? Your mouth goes dry, your stomach drops out, right? Ah, we've got a comment. Okay, good. Okay, so butterflies, great. And your stomach, right? Lanny says your stomach dropped out, right? Physical, yes, Donna, thank you. So here's the thing. That is literally your fight or flight response kicking in. That is your body saying, oh my gosh, danger, Will Robinson. But it doesn't know that you're choosing to do it. So it is literally saying, oh boy, we don't need all this happening right now. We got to get the heck out of here. So I'm going to stop all of these things that I don't really need because I need to be ready to fight or flight for my life, right? And we're going to talk in depth about that in a second. So our respiration, our heart rate, our attention, our memory for threat and energy availability increase, right? This is how that heartbeat goes faster. This is how that breathing rate happens. You start maybe even sweating or you don't, right? Maybe your mouth goes dry. All of this is part of stress because the body defers those future needs, right? That's where that stomach happening is, right? That digestion, it's literally the blood rushing away from your stomach so that it can rush to your muscles so that you can be ready to run or fight for your life. So fight, flight, and chronic stress. We're not talking about that one and done kind of stress. We're talking about the bigger picture here. So what does it look like in real life? So in fight, we're looking at somebody who's dysregulated, they're aggressive, and they attempt to manage the situation. Don't come near me, don't touch me, right? The flight is somebody who withdraws, they shut down, they don't talk, they kind of just, whoop, there's nothing. Freeze. So they've added this recently, and I think it's really important to talk about that because a lot of us who work in psych, we have seen where somebody will, what they say, disassociate. Maybe their lack of focus, maybe they're just off in la la land, but are they? In fact, this has been shown to actually be a production of that fight, flight, or freeze response from long-term chronic stress and trauma. This one I thought was super interesting because I had never heard of this term before. Tend and befriend. This is the person who is clingy, they're caretaking, they overcompensate because they want to do everything for everyone. And it's funny because that's me. And I would have to think probably a lot of the rec therapists would also say they do everything for everyone because we have that can-do kind of personality, right? We know if I don't do it, it ain't gonna get done right, right? Is that a type A, or is that maybe our body's long-term response to stress? Think about that. Put that in the back of your brain because it affects your brain. It affects your memory, your selective attention, your self-control, and the ability to turn off your response. Being chronically wired in this state of high alert, it interferes with our ability to explore and learn from environment and socialize with others. And we know that Vygotsky said that we learn best through what? Through socialization. We know that Piaget said we learn by exploring, by touching, by this. But Vygotsky said, no. We learn by watching others and by socializing with others. And I personally, in my opinion, from when I've seen little ones to older ones to adults, I think that he's probably more on the money with that, right? I know that I learn best. I'm a visual learner. If you show me to do something, I'm going to do it. So imagine what happens when we have chronic stress and we can't learn properly. This I thought was interesting too. States become traits, meaning if we're in a state of constant arousal, eventually we become the high-strung person, right? When you go back to your everyday life, I want you to start thinking about that and looking at other people and be like, oh my gosh, maybe that's a trait. I'm not saying diagnose them, but recognize that it might be that this is their need to kind of maintain control over the stress in their lives. So what does trauma affect? How does it affect it? Let's put it that way. At any point in our life, it's going to have a long-term effect. as we age. And this is why I think it's really important, okay? Because for those of you who do work in skilled nursing, you are gonna see those long-term effects and not realize why. So the amygdala and the hippocampus, those are our two big things that are affected here. During the traumatic event, the amygdala becomes overactive and the hippocampus becomes suppressed and altered. And let's talk more about that. So the hippocampus, as you might remember, is your memory storage. And I remember when I was in I think it was Psych 101 when I was in college. And my professor talked about how the brain is like a huge filing cabinet, right? And your short-term memory, well, that gets filed in the front, but your long-term memories, those go in the back, and we don't remember them until we need to kind of pull them out, right? But if our hippocampus is not working properly, what can that affect? Our memory. Think about over time, what happens? So after experiencing that trauma, the brain might struggle to tag memories with dates and times, right? And we know this as a flashback when we talk about PTSD. But hold on, there's more. So we have those flashbacks that occur due to the senses that are associated, right? Maybe you smell something, maybe you touch something, maybe you even just hear a sound and boom, you are right back. Now, I'm going to tell you, when I was younger, I went on a trip where we actually went to the different concentration camps in Poland. And we had an experience where our group leader put the whole entire group into the gas chamber in Majdanek, which is probably the worst of all of them, closed the door on us and wouldn't let us out. So I come home, now I'm 15 when this happened, by the way. I come home, I am with my mother, we're going to the ballet, we're walking through Lincoln Center, and there's a tunnel that gets you through to the train station. And for some reason, I was triggered and I was having a flashback to being in that gas chamber in Majdanek. And I literally had to have my eyes closed and my mother had to walk me through the actual train station until I could get myself to refocus. And again, I was 15 when this happened. So here I am 20 years later, 30 or 25 years later, and it's still to this day, I can remember everything about that moment. And it wasn't something that traumatically happened to me in the sense of, you know, what we were talking about before, right? Of those perceived versus actual. I obviously was not somebody who experienced the Holocaust, but for me, that was a traumatic event. So that being said, those flashbacks, they can range in intensity, but they have those long-lasting emotional, mental, and physical impacts. Because literally, like I said, I could right now tell you what that room smelled like even 25 years ago. So the hippocampus, it begins the brain's natural reaction to trauma. And it tells the amygdala, as well as our lovely CNS, to display the physical symptoms that the body prepares to actually fight the threat, right? So the flashbacks can occur in the young and the old, but look what it says. Age exacerbates these symptoms due to increased memory loss and alterations regarding context of that past trauma. This is where I found it super interesting because, like I said, we are not just going to be talking about our psych patients. Think about your patients who are in those skilled nursing facilities, who might be sundowning, who might be experiencing something that was traumatic to them, but they can't verbalize that. That, to me, is why trauma-informed care is so important across the population. So age also affects the impact of the physiological symptoms as well. And look what it says. Physical distress becomes increasingly dangerous due to our weakened systems within the body. So it means that we're at a higher risk for stroke, for heart attack, for developing cancer if we do not deal with the stress and trauma in our lives. So take a look at this. I thought this was so interesting. And we were talking about in the keynote, if you were able to attend the keynote, we were talking about the need for more evidence-based practice. And this for me says it right here. Because there was a study at Emory University, and it looked at the hippocampal structure of women who had experienced childhood sexual abuse, okay? It showed that the hippocampus and the women who had this abuse, it failed to activate. And again, remember what the hippocampus does. It's that memory, and it increases the risk of flashbacks and the fight or flight responses throughout their lifetime. So even if it happened when they were a child, throughout their lives, their hippocampus is going to continue to give them these flashbacks unless it is addressed. Look at this. As age begins to affect the memory storage in the brain, the trauma makes the brain increasingly susceptible to diseases like dementia and Alzheimer's disease, because those neurological connections, they begin to decline. So this might be a link. And again, I am not a doctor, so I do not pretend to make that assumption. But for me, that's really interesting, because it seems to me as though there might be a direct correlation between flashbacks and even sundowning. And I'd be interested to see if in fact that could be studied somehow. I don't know, just a suggestion. Take a look here. It also said that the women had a smaller hippocampal volume by 19%. That's huge. We're not talking like 1%. We're talking nearly 20% of their functioning gone, compared to somebody who never had this type of experience. So it really, that's the biggest thing, that fight or flight reaction and their flashbacks, okay? So now let's talk about our amygdala. It's the brain's protection system. It tells you, Molly, you in danger, girl. You need to get something going because we need to run, or we need to fight, or something needs to happen, right? And if any of you have ever walked down a dark city street before, like I have, you know that your hearing starts going better, your eyes are dilated, you are on it, right? You know what is going on, you hear everything. And that is your body responding to that fight or flight. But after experiencing the trauma, your body can't tell what's real versus what's perceived. And that's really important, especially when we're talking about those who are even, you know, maybe those who are sundowning, right? It leads to an inability to decipher between physical and psychological threats. And you might develop symptoms when you're coming face to face with both the angry animal or creating a presentation, because both of these are similar in your brain telling you, uh-oh, Molly, you in danger, girl, right? There are fears that we don't know how to deal with. So let's go back for a second. Our physical symptoms, right? Heavy breathing, sweating, rapid heart rate, and trembling. Again, all of these are things that we, if it's once in a while, okay, fine. But over time, like I said, the studies have shown that you are at a higher rate of chances of developing heart disease, high blood pressure, having a stroke, having cholesterol block your arteries, developing cancer. You're at a higher rate of risk for all of these long-term physiological effects if you do not learn how to deal with the stress and the trauma in your life. They become emotionally and mentally exhausting due to the inability to process those symptoms or change our perspectives regarding that trauma. That is huge. Because think about how exhausted your body is going to be, right? I know when I go to an amusement park, if I am brave enough to even put myself onto a roller coaster, side note, I'm not. But when I do, afterwards, my whole body is so tense. I'm drained because of the physiological responses that I've put my body through. So what does it mean for our clients? It means that no matter where they are in their lifespan, their trauma affects everything that they do, even if they don't realize it. So it shapes our beliefs and our expectations about ourselves, because I'm not worthy of love or care. I'm helpless. I need to be constantly on alert, or I need to be in control, complete control, so that I can feel safe. And I want to pause here. I want to stop the share because I want to ask you guys, so far, have you seen what we're describing in your patients, in your residents? Because I think it's really important for you guys to be able to recognize what you're seeing versus what we're talking about. So has anybody experienced this before or seen this in action? Okay, so Lani is saying yes. Lani, do you want to unmute and share? Putting her on the spot.
Oh boy. So yeah, I work in a psychiatric hospital, and you know, I get to see the clinical, the nursing assessment, and then I get to meet with the patient and do my own activity assessment. And you know, across the board, there's all different types of trauma, between, you know, being raped by a family member, you know, an older brother's friend. I mean, there's just.
Oh, we lost her sound. Oh wait, Lani, we lost your sound. Oh no. Lani.
On a couch talking about it, going through activities, it kind of gets them to talk more sometimes when they don't even realize it.
Okay, so I'm going to tell you we lost a good chunk of what you said because your sound cut out, but at the end, I want you to repeat what you just said. That when they share in activities. Yeah, now I can hear you.
Okay.
But I want you to share that last sentence that you said, because I think it's really important that when they come to your activities.
Right, or when I do a one-to-one with them, you know, just having maybe a catch with them, or playing basketball, or playing Uno with them, and they open up more because they're not just sitting on a couch with somebody staring at them and trying to get stuff out of them. So actually doing it through an activity makes them feel more comfortable and at ease, and they talk more. And then you can go back to their therapist and tell them, you know, report to them what happened during your one-to-one, which will help the patient in the long run.
Right. I find that, you know, I always tell my students that what we're doing is sneaky therapy, because our patients don't realize what we are doing with them, that we're doing therapy, until after, and they go, hey, wait a minute, you taught me something. Yes, I did. Because that's the most important thing. We have to realize that we are interacting with them at all times in their lives. And we are probably going to be the ones that they're going to share with most of all. So Matthew is saying he sees multiple fight, flight, or freeze every day with the youth. He sees and he hears different triggers. And that is 100% true. You know, I think it's really important to note that, especially those of us who do work in youth psych, you're probably going to see that a lot more, like, in every day, right? I've had kids get triggered by the sound of the bell in the school, because for them that brought something back. Maybe they were, you know, bullied in school, or something happened in the school itself, you know. I once was walking with one of the kiddos, and I was talking about how my cat used to come up behind me and push me, like, because he's a jerk. And she was really upset because she had a trauma where somebody had come up behind her and assaulted her. And so I did not realize that, because that was not part of her trauma history that we had discussed. So I had to change my way of engaging with her because I didn't want to re-traumatize her while we were doing our program. So it's things to think about like that. And I think that it's really important to recognize, and so Matthew says that during different programs, youth are going to open up about what's really affecting them. And that's absolutely true. Like I said, and like Lanny said, they open up to us more than they probably ever do. And I can't tell you how many times in the last week I've said, it's wonderful that you're telling me this, but you need to tell your therapist. You need to tell the doctor, because I don't mind being your mouthpiece in certain instances, but I need you to start asserting yourself to be able to tell them what you are feeling. Because if you can't do that here, when you go home, now what? You still are not going to be able to share that. So let's work on how are we going to verbalize that. Matthew is saying different sensory foods, balloons popping. Yes. Sounds, smells, activities, they do. They affect different youth. And I'll tell you, they affect adults too. And so, we're talking across the lifespan, 100%. I've had, adults, elders who get re-traumatized or re-triggered by every little thing. And so it's really important to really be informed in that trauma-informed care. So let's come back to our slide here. So, we got another comment. Awesome, great. Oh, hold on, sorry, I clicked the wrong thing. So it says here, Lanny says they have a code word with the patient can say when they're getting, that's beautiful, I love that. So Lanny says that they have a code word that they set with the patient so that the patient can say that when they're getting triggered so that they know not to continue with whatever is going on. I think that's brilliant. And I love that. And I kind of want to bring that back to my facility and see if we can kind of use that. Thank you, Lanny. That's great. So trauma, it shapes our beliefs. It also shapes the beliefs of those who care about the people who care for us. Mainly, people can't be trusted to protect me because they're only gonna hurt me, right? And I'm sure, especially those of us who work with kids, we hear that a lot, but even in the older adults, think about how many times you've had somebody who's in the middle of, an agitated state, as they call it, saying, I don't know you, I can't trust you, get away from me. I've had that happen before when I worked in skilled nursing, many times, where no matter how calming my voice is, it's okay, we're right here, don't worry, just come back to my voice. No, there is none of that in the moment. They are experiencing their trauma. Also the world in general, right? The world is a dangerous place. I can't let my guard down. And I think, there's something to be said about those of us who grew up in the city where, okay, fine, I can't let my guard down because I'm a city kid and I have to make sure I'm looking around at all times, versus the combat veteran who comes back and literally cannot let his guard down, or her, excuse me. There's the difference, right? Whereas, you realize that, like, yes, okay, I have to be smart and I have to be aware because, yeah, I'm walking out of the train station at 10 o'clock at night, but it's different, right? Donna says hypervigilance, absolutely. And we know that that's part of that PTSD in and of itself. But again, unless somebody is actually diagnosed with PTSD, how do we know? If they're not willing to share, and especially if you look at the older generations, right? Think about, the greatest generation, as they called them. My grandparents, those who, the ones who went to war, who saw these horrific things, who are now in your skilled nursing facilities, and they're not going to talk about it. Or even those of, my parents' generation who were in the Vietnam War, where they will not, my uncle, he was in the thick of it. He would never talk about it. Never said a word, right? Because there was not something to be talked about. Think about all of those types of different traumas and then bring them into your everyday life and recognize that the people that are around you, who you work with, who you live with, who you love, who you care about. Everybody has some kind of trauma in their lives. So again, this affects how your clients interact with you, the patients, the residents, and the staff, right? I once had a patient who was calling one of our CNAs, and excuse my language, a jigaboo. And I was like, oh, no, we do not. Yes, Lanny's face says it all. Lanny's like, oh, yes, because that for him was an appropriate way of calling somebody a person of color. And I was horrified by it. So again, how do we tell them this is not appropriate, right? Fiona is saying they see it as talking about it as a form of weakness. And you're absolutely right, Fiona. And this is where that generational gap really is something to talk about. Because, you know, I think nowadays, I always say that the generation, like my niece's generation and the generation of kids that I'm teaching right now, they're going to save the world because they are more caring, they're more accepting, they are more loving-ish, right? We have kids that decide that they're coming out to their true selves and they are transgender, right? And so the staff that we have, God love them, you know, we've had trainings, but in the beginning it was like, oh, no. But our kiddos, oh, I think this skirt would look really great on you. Oh my gosh, let's do your nails. Oh my gosh, they just come right into it. But that older generation, like Fiona says, they see it as that, talking about it as a form of weakness, right? That quote unquote toxic masculinity that we always hear about. That's a generational thing. That was, we don't talk about it. It happened, it was in the trenches, and don't even expect me to talk about it with you because I don't think I could talk about it. But they have to. Otherwise, what's going to happen, right? So this is why trauma-informed care is important for all of our populations, right? Every single person. If you are interacting with somebody, you have interacted with somebody who has trauma. And that includes me, it includes you, right? If every one of us sat here and talked about the traumatic events of our lives, we might come together, but we also might not want to share that. So how do we move forward from it? So take a look at this for a second. Just kidding. There we go. Sorry, technical difficulties. Take a look at that. Trauma-informed care, the road to it, okay? It provides introductory training to all staff. Again, it's not just at the staffing level. It is about organizational culture change. It is about recognizing that everybody who's involved in this person's care has a responsibility to act as if they are trauma-informed, right? It addresses any potential re-traumatizing policies and procedures, organizational, right? It establishes an internal trauma team. When I was at Mid-Hudson Forensic, I was part of the trauma response team, and it was not for our patients, it was for our staff. And if a staff had an incident, they had trauma. So we would go and we would ask the staff, do you need to talk to somebody? What can we do to help support you? At my facility now, it's called ASAP, the Assaulted Staff and Something Program. Does it always have to be physically assaulting though? No, because honestly, there are plenty of times where something that one of the kiddos says to me, it throws me. And I have to go, oh, wow. Okay, that's something I'm going to think about for days and days and days now. Okay. So again, it's an organizational level. It is not just about how do we help the client. It's about how do we help ourselves and each other work with this. So there are some basic benefits to trauma-informed care. It's going to improve your patient engagement. I guarantee it. Because if a patient feels more supported in everything that they're doing, they're absolutely going to be more engaged in their treatment. They're going to be willing to come to programs. They're going to be willing to come to groups. Oh, great. Thank you, Dan. Dan says that it's really great that our facilities have been doing that. I honestly think that every facility should have this. And if you don't have that at your facility, maybe you can look into being the one to start them. Because again, it's not just in psych that people have traumatic events, right? I remember once I was working at Elizabeth Seton Pediatric Center, we had a kiddo that had been hit by a car. And she basically she went from a perfectly functioning teenager to learning how to walk, talk, all of that. But with her TBI, she thought it was hilarious that she would grab onto people's genitals and hold tight. So we once had a patient, she came right up to me and she just grabbed and would not let go. And so it was pretty traumatic for me, right? But it wasn't like oh, ha, ha, but I had to laugh it off because, well, what are we gonna do, you know? If there were some kind of program like this at my facility, it might have been something that could have helped me. And again, yeah, okay, in the grand scheme of things, her grabbing onto my bosom, it's not that traumatic in the long run. But for me in the moment, I was like, whoa, that's my personal space you're invading here. Did she mean harm by it? No, she thought it was hilarious. A lot of times what we think is really funny is really, really upsetting to people, and we don't realize it. So it also improves their treatment adherence. And again, I cannot say this enough. If your patient is not engaged in their program, in their treatment, they're not going to succeed. They have to be wanting to do this, right? They have to be willing to work towards it. And the first step is getting them acquainted with their treatment plan. Because if they don't know what the blueprints are, how the heck are they gonna know how to build the house, right? So we have to help them by adhering to their treatment. And in order to do that, that's by addressing that trauma, okay? It's going to improve your success rates and your treatment outcomes, as well as for those of us rec therapists, our attendance. It's going to improve our goals and objectives and how we implement them. And it's going to improve those patient satisfaction surveys that I'm sure everybody has to deal with, right? We all have to deal with what's going on. Do we have to get rid of this program? How do we evaluate it, right? This kind of stuff will help with that as well. So in real practice, how do we implement this across our populations? And we have to realize that even though you might not work with that, you are going to have this. And I said this before, and I left this up again because it's so important to recognize that. It's up to the rec therapist and the treatment team to ensure that they're acknowledging this and addressing the behaviors or those beliefs that might stem from these experiences in both a safe and therapeutic manner, right? We always, no matter what population you work in, you need to work with your patients in a safe and therapeutic environment. And that's not always going to happen unless we work actively to do this. So before you implement these interventions, we're going to talk for a second about how to even move forward with this. Firstly, you have to understand your personal motivations, your thoughts, and your feelings. Because if this is because you're trying to make your life easier so that the patient is less aggressive at 3 o'clock, that's not the motivation we're looking for here, right? We are talking about how are we going to move our patients forward? How are we going to help our clients? That should be our motivation. What am I trying to achieve? Is it so that I can have a better day at work, or so that I can really make a difference in my patient's life? See, I got ahead of myself. What would be our ideal outcome? Is it their success or is it ours? What advice would I give to someone else if they were in my situation? And again, I always go back to how would I want my uncle to be treated? How would I want my parents or my siblings or my spouse or whomever I care about, how would I want them to be treated if they were experiencing a traumatic event, or if they were re-experiencing a traumatic event? This is what sets us apart, I firmly believe, from the other disciplines, because we treat the whole body, right? There's that joke that PT treats the upper half, PT treats the lower half, OT treats the upper half, but rec therapy treats the whole body. And those 5 domains, as Susan was talking about during the keynote, it's so important to recognize that. We treat the whole human. And if we don't recognize how much we impact their treatment, give yourselves a round of applause, because you're the reason why some people get out of bed in the morning. Just wanted to put that out there. And again, how do we make this a therapeutic intervention? And I think that, you know, if I made Fatima turn on her camera right now and turn on her microphone, she'll tell you she's probably really sick of me saying this, because throughout my class, see, she's right there, throughout my class, Fatima will tell you that I always talk about how do we make a program go from just rec to rec therapy? How do we make it actually therapeutic? And so Dan is saying we have to be at our best to help others. And it's super important that the organization is trauma informed for staff for that reason. And you're absolutely correct, Dan. This is where you can now go back to your facilities and advocate for trauma informed care, and recognizing the benefits that it will bring to your staff, your coworkers, your patients, all of the above, if we simply implemented this type of reaction, okay? So yeah. So how do we make it a therapeutic intervention? How do we make it go from, well, that's a really nice rec program, to, wow, that was recreation therapy at its absolute finest? How do we do that? Ultimately, obviously, we know any goal of any intervention is to really make it therapeutic. And we're talking about from the assessment, straight through to the intervention, straight through to the documentation. And again, my students will probably tell you they're so sick of hearing about APIDE, but it really and truly is exactly how I call it the meat and the potatoes of our job. That APIDE is literally why we do what we do. And in order to make something therapeutic, from assessment to implementation, we have to be trauma informed. So how do we do this, right? So we start with discussing trauma even during the assessment, right? And again, it's not always going to be super easy and comfortable to do. When do we broach it, right? Is this a good time to talk? Again, we're not going to do this in the day room. We are not going to put our patients in that feeling of uncomfortableness, right? Because ultimately our goal is to make sure that they are feeling comfortable so that they do want to talk. We're gonna maybe even schedule the conversation. Okay, so I see that you're here and you're playing cards with everybody. I'm gonna come back in a little bit if that's okay. You know, I'm gonna take you, we're gonna talk by ourselves. Is that okay with you? Right? Always go back to the autonomy of, is this okay? Do you mind? I hope it's okay if we just sit and chat for a few minutes. We're gonna eliminate the distractions, right? Because ultimately, if I know that somebody over there is playing a really great game of Uno, I'm not going to want to sit and talk to you, especially my kiddos, that's for sure. So if I take them out of the stimulating environment, they're going to be more willing to probably talk to me about A, what brought them here, and B, what are they looking to get out of this place, right? And again, it might be that they've had 5 different people asking them the same darn questions over and over and over again. But you might be the one that they're going to be telling about the trauma, because you might give them that feeling of safety. So We have to communicate with our patients about what we can do through rec therapy and what we'd like to see from groups with them, right? What are our expectations, right? And we talk about this, especially, you know, when we're studying recreation therapy, we're talking about how we make an intervention a therapeutic one, right? And we're talking about how to literally teach them, not only in the moment, but even before. So here's the groups that we have, and here's why I think it would be really great for you to come. You told me you love music. I have a really great program called Music and Emotions. And I think it'll be really helpful because I think that whatever is going on in your life, if you're telling me you use music as a coping skill, this is the program for you, and here's why, right? You're telling me you love to draw. Well, I've got an art therapy program with my art therapist that's going to knock your socks off. This is when we do our little elevator pitch to our patient. It includes identifying modalities we'd recommend and how they can help them. Because again, it's what makes us go from just rec to rec therapy. We're showing them that it is goal-oriented, right? We're not just saying, well, sure, we've got a Java and Jazz, it's going to be super fun, you should come. No, it's, I think you're telling me that you feel socially isolated, so I think that this Java and Jazz group will be a great way to kind of get you started in getting to know people. And when you're ready, we can do smaller groups from there. But you know, if you don't feel comfortable, you can just sit on the side. So, what don't we do when we're implementing these interventions? We absolutely need to avoid accusatory or critical phrases, right? And in the beginning of this session, I talked about how one of my kiddos said that the yoga in the gym was triggering her, and I kind of rolled my eyes. And I specifically did that because with this child, that was not trauma, that was not being triggered, that was she did not want to be in the gym and thought if she threw that word around, it would give her the result she was looking for. And it did, because I'm never going to force anybody to stay in a program, especially when they're voluntary. But we're never going to accuse, and we're never going to be critical of our patients, right? We're never going to say, oh, that didn't happen, you're totally lying. Even if they are the boy who cried wolf, even if we think that everything that's coming out of their mouths is not true, that's not okay for us to make that judgment, okay? So the more we do that, the quicker they're going to shut down, and the less likely they're going to be willing to talk about whatever's going on in their lives in the future. So we're also going to make sure we don't minimize their pain. Again, this is not Trauma Olympics. We are not trying to say, oh, I had it worse than you. Imagine what I went through. No, because it's not about us, and it's not about the other patients, and it's not about them comparing, well, who had it worse. Because you know what? Everybody's perception of their pain is their own. And we don't get the right to tell them what is or is not their pain. We can't give ultimatums. Well, if you can't talk to me about what's going on, you can't come to this program. No, that is absolutely the opposite of therapeutic and the opposite of what we're looking to do, especially in trauma-informed care environments. And most importantly, we can't expect others to be mind readers. We can't expect that they're going to understand what the program is about. We're not going to expect that they understand what we are looking for them to get out of it. And that's why it's so important to remember to tell them, here's why I think this would be a great activity for you, right? The other thing is that if we're mindful of those triggers and those traumas, if we know in advance, we can make sure to kind of plan ourselves around others, like make sure, how do I phrase this properly? Make sure that we are not adding to the trauma, and that our staff and our coworkers and other patients are not adding to the trauma as well. But that happens by, well, especially not the patients, but with the staff, it happens by letting our staff know and our coworkers know, hey, listen, this happened, so maybe we don't really talk about it because we don't want to trigger the patient, right? Little things like that go a very long way. You know, when I worked in forensics, it used to be that we would share information by being like, okay, so this patient has a history of X, Y, and Z, so I want you to be careful when you're blah, 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 right? This is because I might not have worked with this patient before, but I'm that patient's type. And they know that they've enrolled him in my group. And, you know, my coworker comes in and says, hey, listen, I know you've never worked with this patient before, but the person that they assaulted looked just like you. So you need to be aware of that and be careful. I wouldn't have known that if I did not get told, because I was not a mind reader. This is why it's important to share that information. So we have some general tips. We're going to help them to identify what they're feeling. And sometimes they don't understand what they're feeling, right? A couple of years ago, I presented on the use of anger management as a recreation therapist. And we talk about the anger iceberg. And we talk about, if you've ever seen an iceberg before, you know that the tip of it is what's above the water. And the rest of it is underneath and you don't see it, right? We all saw Titanic. We know what happened. So we talk about emotion icebergs, right? Where the behavior, what we're seeing above the surface, me throwing a chair, right? All you see is me getting up and throwing my chair. But you don't know what the behavior is spurred by. Maybe I was supposed to have a visit from my parents and they forgot. And so when the person that walked in and said, I just had the greatest visit with my parents, well, now I'm gonna throw a chair. But guess what? I didn't share with anybody that I was supposed to have a visit. My parents said to me last night, I think I'm gonna stop by today. Okay, great. And then they don't, right? So sometimes they can't identify the behavior of what they're like, why it's linked. Oh, good. I'm glad you listened. Donna's saying she likes the iceberg analogy. And what I'll do is when I send out, if you guys want, you can, at the end of this, you can comment your emails and I'll send out the PowerPoint and I'll send you the anger iceberg, the worksheet that I use, because I think it's really important to be able to do that. Because again, we don't know why sometimes, especially young people and older people, they don't know how to identify what they're feeling. They're feeling sad, but they're displaying frustration, right? They're feeling lonely, but they're displaying cantankerousness, right? Like, oh, get out of my room. I don't want you anymore. But guess what? It might just be that they're feeling super lonely, but they don't know how to verbalize that. This is where we come in. You say, listen, okay, I understand, you know, you want your space, no problem, but whenever you're ready, I'm here. And if you'd like, let me know and I will happily come back. Okay, Kathy, I will definitely send that to you. So like I said, guys, everybody definitely. Lani says, now it's even worse because there are no family visits because of COVID. And that's absolutely true. And later in the next session, we do talk about that loss from COVID, right? Obviously the global loss, but also that idea of, you know, I mean, with my kiddos, it used to be that the parents could just show up at any time and they could spend hours upon hours visiting with their kids. Now it is, they have to arrange it with the therapist and it has to have a therapeutic value to it, okay? That's a big issue. And I know that Susan touched a lot on that during the keynote speech about how, you know, we as rec therapists, we have stepped up. We have held iPads while wearing full PPE. We have been the bridge, right? In my article for the Nystrom newsletter last time, I wrote about how I have one of my very best friends growing up. We both grew up together, obviously. She became an OT and I became a rec therapist. And she called me one day and she said, listen, Shari, I have to tell you, I have never been more grateful for recreation therapy than I have been in this last few weeks. And this is just in the beginning of the pandemic. And I said, why? What's up? And she said, well, my mother, you know, has been in a skilled nursing facility because she has a degenerative muscular disorder. And the rec therapy department is the only reason why my daughters can see my mother from where we are, because we used to drive down. She lives in Maryland. We used to drive up and we used to come and see her every couple of weeks, but we couldn't do it. But because we have that scheduled Friday appointment, every Friday, my kids know that they're going to be able to see their grandmother for the time that we have. And that right there, it's huge, right? So we're going to build on that talk, right? And we know this. These are things that we know as rec therapists that we put into practice every day. This is the stuff that we build on those relationships, and we can then use that when the patient is in crisis later to bring them back. Hey, remember when you were telling me about blah, blah, blah? Let's talk more about that. Why don't we go and sit? You and I will just go, we'll sit, we'll have a good time together, right? All right, but you got to be safe. I can't have you come with me if you're going to be threatening people. But can we do that? What do you think? Can we go take a walk? Let's go look at the fish tank, right? All of this is what we're building on. We are building the therapeutic relationship so that we can engage with our patients and they can feel supported. We have to acknowledge that the pain is individual, okay? Every single person addresses their trauma differently, positively or negatively. They are all individual, and every person is allowed to feel what they feel. And we can't push them towards feeling it quicker. They have to be ready for it. Because if we push them towards it and we rip off that Band-Aid, but we're not prepared to cover it back up with a gauze, they're going to bleed out. And that's not fair to them. Oh, thank you, Leah. So we're going to use active and reflective listening. And we talked a lot about that. And I don't know if you guys have been in the other sessions that I've been attending a bunch of different sessions. Active and reflective listening, if you've never used it before, it's literally just the act of being present in the moment with your discussion with your patients, with your clients, your residents, whatever you want to call them. It's the body language of leaning in. It's putting your hand on your chin or under here, or nodding your head and looking straight at them, not looking at my phone as it's time, right? Not looking around. It's being present. It's saying, okay, so let me understand what you're trying to tell me is, correct me if I'm wrong, is this what you're trying to tell me, right? Because it could be that they don't realize what they're saying, or it could be that you're not really understanding. So you want to make sure that you're getting what they're putting out there. That goes a whole long way in creating that therapeutic bond. The biggest thing I need for everybody to understand before we end this session, and we'll start again on Wednesday, but you have to acknowledge that these emotions are going to go so much deeper or so much more intense than a 45-minute session that you're going to have with them. So you have to foster that interdisciplinary collaboration. Again, you cannot rip off that Band-Aid and then send them away gushing blood everywhere, right? And I know that's a pretty big visual, but think about that, right? If I rip off that Band-Aid and go, bye, that's not fair to them. I remember once I tell this story in my classes about how my first time ever really doing my music and emotions group, I worked at Children's Village, and we worked in a crisis residence, and my kiddos were all in foster care, and they all were, basically there for 21 days for crisis stabilization. It was a step down from hospitalization. And I'm brand new rec therapist. I think I know what I'm talking about. I got this is good. So I go and we're talking about anger. Yes. And I played this song. And if you've never heard of it before, it's called Father of Mine. It's by, oh gosh, I forget the name of the group right now, but Everclear. And basically the lyrics say, "Father of mine, tell me, where have you been? You know, I just closed my eyes, my whole world disappeared." And slowly but surely, I see all of my 8 kiddos start getting upset. They're rocking back and forth. Their legs are going. They're getting all mad. One by one, they get up, they go out of the day room, and each one of them goes to their room and starts trashing the place. My bad. I had 1 kid left by the end of that song, and I had to leave. We did this program at 7 o'clock, and I was out at 8 o'clock. What did I do? I just set up my coworkers for failure. And that's not fair to them. And that's not fair to the patients either. So my learning mistake should be your word of caution, right? And that was something that I never will do again, because I did a disservice to my patients and to my coworkers. That was not trauma-informed care, and it was not cool, right? So I think we can pause here if everybody's okay with that. It is just about 9 o'clock. So I think what we'll do here is we will pause here and we can start again on Wednesday. Okay, great, Fiona, thank you. Everybody, if you haven't already commented, please comment below so that you can make sure I get you your CEUs. Now, like I was saying, if you joined us right after the very beginning, what I had said was, on Wednesday, there is the second session of this course, okay, where we're actually going to learn how to implement these types of discussions using different modalities. Now, if you cannot make it, Lani had said that she has to work on Wednesday night. So if you cannot make it, you still can view it once we post it on the Nystra YouTube page. Oh, great. Thank you, Lani. Lani says it was great. So you can watch it on the YouTube page, okay, and still get credit for it, okay? So what I want you to do is, again, I hope that you join us. I hope that you got a lot out of this. My biggest thing is that, no matter what population we work in, we do fabulous work. And like, Susan said, we are awesome. We are amazing. And the more that we can share what we do really with our clients, with our staff, with our coworkers and leadership, the better off our patients are going to be, and the better off the world is going to be, to be honest with you. I think everybody needs rec therapy, to be honest. But so that being said, again, if you cannot make it on Wednesday night, you can view the session like I said, on the YouTube page. But I do hope that if you can make it on Wednesday, that you do, because the reason why we very specifically made this into a live session as opposed to me recording over is because especially next session needs to be interactive. We need to have those discussions so you can see how to foster those kinds of discussions. Okay, so if you can make it, yay. If not, no worries, I get it, watch it, but you will not get credit or CEUs for these 2 sessions unless you attend both, either physically or watching it after, okay? So please, please, please don't waste your time. You sat here for an hour and a half listening to me, ramble on. Watch the other half if you cannot make it in person, okay? So I really very much appreciate it that you guys came tonight. I know it was a long day. I know I had a long day. So I very much appreciate it. And I hope that you got out of it what we wanted to share with you. So thank you very much. And I hope everybody has a wonderful evening. And hopefully I'll see you guys on Wednesday. Okay. So good night. Be well. Thank you.